good afternoon, good evening, good night for some of you. I'm very happy to welcome everybody for the launch of the Global Health Expenditure Report 2020 of WHO. This report, many of you already know this, but is based on the Global Health Expenditure Database that is sometimes known as the GHED with the nickname. This is a global public good that is with WHO. That has a system that is transparent, of transparent access to health expenditure data, and that has also data that is comparable across countries. We are going to hear about this report from many different perspectives, but of course, this year we have the very important topic of health spending and COVID-19 expenditures related. What do we already know? What can we already conclude? So all this is going to be addressed during this launch. The session will be divided in 4 blocks. The first one will be with opening remarks from different perspectives. Then we'll have the presentation of the report itself, plus then panelists that will be organized in different categories of stakeholders. And we will finish just with some concluding remarks and a wrap-up. I would like to start with the opening remarks. And the first person that is online with us for the opening remarks and that will bring the WHO regional perspective, and more specifically from EMRO region, based in Cairo, our friend Awad Mataria, who is the director of UHC and health systems in WHO EMRO. Awad, up to you.
Thank you very much, Claude. It's a great pleasure to be with you and with all colleagues, and it's great to see many faces, many pictures of colleagues whom I really miss. And I hope that one day will come soon that the pandemic is behind us. This is something, it's a practice that we spend many minutes nowadays in every meeting that we just request colleagues to mute their mics. So sorry for that, please. Well, I want to reiterate to say that I'm really privileged and feel humbled for this opportunity of joining the launch of what becomes really a landmark annual report that WHO produces on global health expenditure that is attached to the GHED, the Global Health Expenditure Database, as Claude has referred to it. Colleagues, every year there is a theme that has been selected for this annual report, and the theme has always been of high policy importance. I estimate that the theme that has been selected for this year is even more relevant from a policy point of view and more timely, given all the challenges that the world is living due to the COVID pandemic. For me, the Global Health Expenditure Database, and for many indeed, has become a model of what is a global public good. It is something that is being valued, becoming more and more valued by a wide spectrum of stakeholders. And I can refer to policymakers, to practitioners, as well as researchers, and we also people working in development and the development world as we work with countries to improve the situation of the health of their population. At a personal note, I want to share that the last week only, we received a comment, our regional director, and we received an email from one of the member states, from a senior official from a member state, who was commenting on one of the numbers that he has seen in the Global Health Expenditure Database. I felt really thrilled and very happy, because that meant that this senior colleague from the Ministry of Health of that country has spent time and has checked and examined the numbers that were there. And it has engaged a lot of exchanges between the regional office and between headquarters to see why there is this discrepancy in the numbers. And it allowed us also to provide explanation and justification. I'm mentioning this to say that it is really becoming a global public good. It is something that policymakers are very keen about. But given that we are living in this world where we are all hit by this very severe pandemic, I cannot not mention how we are looking at this question of health financing and health expenditure in the context of the pandemic. I believe that all of us agree that this pandemic has taught us many lessons, and many lessons in the hard way. But one of the lessons that I personally learned from this pandemic and many others is that health is not only a factor of development, and I'm very pleased that Professor Ilona Kitbush is with us. It's not only a factor of development, but it is that there is no development without health. In our region, the Eastern Mediterranean region where I serve, for a long time, we have been signaling to our member states that we are not investing enough in health. Based on the latest numbers that we have, our region is spending less than 2% of what the world is spending on health, while we represent more than 9% of the world population. So we have been talking about this, trying to advocate, trying to reach out to ministries of finance, to allocate more money for health, to show health as being a factor of development, not only a sector that is absorbing and that is a sector where money is being spent only without results on development, on improvement of the health of the population. But with this pandemic, now we have bettered the ears of colleagues from ministries of finance, ministries of national economy and development sector, where with the evidence that is provided to us through the Global Health Expenditure Database, we can argue more for the importance of investing in health. My other point that I feel is becoming more and more relevant and more important indeed, that through the Global Health Expenditure Database and the report that we publish annually now, we focus more on intra-country or comparing the country with itself. There are some comparisons between countries and between regions. I think what is important and what I see in discussing with policymakers in countries is that they are more concerned about comparing themselves with themselves. So to look at climate trends, look at how things have evolved over time. And what the Global Health Expenditure Database has shown is that when they report the real numbers, when they invest in actual data collection, they are able to get quality data to be able to compare themselves with themselves, to assess the different policies that they are undertaking in their countries. So again, for me, this is a very important value added of this global public good. But also the numbers that we are sharing and we are producing annually in collaboration with everyone. So within WHO, but also across different agencies and development partners, has become really a good source for policy dialogue and policy guidance. And that is something that we will continue working on. And I look for the leadership of everyone in facilitating that important undertaking. My last comment at this stage, again, going back to the question of COVID and all the thinking that has gone through the health system work and how our health systems have been really not prepared for such a pandemic. I mean, no country in the world has had made the right investment in their health systems to be able to cope with this pandemic. Is this a question of investing in the common goods for health and the importance of investing in emergency preparedness? So I know that at this stage we have some numbers that are useful to reflect how much countries have been investing in emergency preparedness, but not enough. I mean, in the coming year, hopefully, we will be able to get more data, more analysis to be able to report on how much countries are investing in emergency preparedness in the essential public health functions in the common goods for health. So with this, I would like to hand it back to Claude and looking forward to a great session altogether to learn about the key messages that this year's report has came up with to guide our policy dialogue and our advice to countries in improving the health financing system moving forward. Thank you very much. Back to you, Claude.
Thank you, Awad. The next perspective that we would like to introduce is the broader UHC movement. And for this, I would like to give the floor to Ilona Kickbush, who is the co-chair of UHC 2030. Up to you, Ilona.
Thank you very much, Claude. Good morning, good afternoon, good evening to all, as we say. And I'm, of course, thrilled to be here with you and on the occasion of this 2020 edition of the Global Report on WHO Health Spending. The subtitle is Weathering the Storm. I'm here in Bern, Switzerland, and we just have a snowstorm outside of my window. That is truly expressing where we are right now. One of the issues, of course, or the positive things of this situation right now that we're all meeting virtually is that we can keep track and even participate in many of these important meetings and launches that are happening now and leading up to the UHC Day on the 12th of December. And so many important perspectives are coming together. Over the years, as was already said, this report has really become an annual landmark that is so critical for the UHC community because it brings together rich and, even more important, accurate information on health spending at country and global levels. I think we can't stress this enough. This is reliable information. And in times where so much of health has become so political, the role of reliable information just cannot be valued enough. The National Health Accounts Expenditure Database, which of course is at country, regional, and global level, and all the annual reports, have become a really central instrument for accountability. And as you know, UHC 2030, and particularly the civil society within UHC 2030, has put accountability very, very high on its agenda. And for accountability, we need sound, data-driven, real country-based resources. And of course, some of you have already indicated how important these data, these resources are for countries. But of course, it goes far beyond that. It's important for academia, for the analyses we do. I've already mentioned civil society, how important it is for civil society to have data. And then, of course, within the government, it's many different actors that need to be able to access such data, not just the ministries of health, but the budget commissions, various health commissions, parliamentarians, national health assemblies, and budget watchdogs. So I think also in terms of advocating for this report, I think taking it forward, particularly to parliamentarians who are taking an increasing interest in universal health coverage. And we from UHC 2030 have been working with the International Parliamentary Union on this, will be very important. And it's my plea to all of you who are present here to make sure that the parliamentarians in your country get access to this kind of information. And that's really also what makes it a public good, a global public good also because of the transparency and the ability to compare, but also global because of the many, many different players and actors that can use it. A little bit, Awad has already also alluded to the fact that in this year, the report is even more important because it comes at the end of a very dramatic and very particular year, something that will go down in history probably as the year of COVID-19. From UHC 2030, we've put together 3 messages that seem to emerge in our view. First, while there has been good progress and spending on health that has been steadily increasing over the past 2 decades in all country income groups, we feel that the health financing model that was developed over the past 2 decades had, and here I quote, clay feet, profound weaknesses that were of course revealed by the COVID-19 pandemic. We do have to go back to how we look at financing, and I think particularly the underestimation, the undervaluing of public health is one of those issues that we will need to take forward much more consistently than we have in the past. And of course, you will know we issued a report from UHC 2030 on the interface of health security and universal health coverage, that all these kind of financing interfaces and dynamics will need to be looked at much more carefully. And also what has proven to be some of the weakest parts and most vulnerable parts of the pandemic, of the health systems in the pandemic itself. And of course here also the payment of health workers, particularly female health workers, is a thing to be considered. We looked at the lack of investment in common goods for health, the focus on diseases at the expense of public health functions and health systems, the heavy reliance of low and middle income countries on out-of-pocket spending, the reliance on labor taxes in some countries to fund social insurance, leading to a drop in access when unemployment rises, as it is doing right now. And finally, the fungibility of our aid modalities. We have started to see that in global health and development, we are no longer talking millions, we're talking billions. And that means we really have to rethink how we approach the financing of common goods and at national and at global level. And we were particularly struck by the fact that lower income countries were more AIDS dependent in 2018 than in the year 2000, and how that might change again in the present situation. Second is, we've mentioned it, the profound impact the pandemic has had on this backdrop. And again, the focus we will need to have not only on the financing itself, but on the financing architecture. And this financing architecture, we hope, will also be taken up by a new WHO initiative. Some of you might have heard that the Director General has appointed a new WHO Council on the Economics for Health for All. And this council will particularly be looking at these kinds of issues. We feel from UHC 2030 that we should move out of a framework focusing on burden of disease of yesterday towards a new compact through which we invest in health systems of tomorrow, systems that will be able to address pandemic risks, but will also be related to the environmental threats on human health, survival, and climate change, but also systems that take into account the enormous digital transformation that is underway. And finally, we want to highlight the message of opportunity that this report also gives. The opportunity, we've used many different words, build back better, reset, reimagine, and actually get a better feeling for what are the health challenges of tomorrow. And there it has been quite exciting to introduce this step zero of UHC, investing in common goods for health, investing in preparedness, essential public health functions, and investing in collective action, because we also need to invest in the infrastructures for participation, in the infrastructures for civil society. So that is what UHC 2030 has called on, to really invest and support civil society platforms so that they can push their governments to take action. So the findings of this report are timely for UHC Day, for our campaign, Health for All, Protect Everyone, to end this crisis, we say, and build a safer and healthier future. We must invest in health systems that protect us all, everywhere, now. And we think this report will be an important tool so we can start the change now at country level, at regional, and at global level. Thank you very much for giving us this opportunity. Thank you.
Thank you very much, Ilona. The third opening remark will be, of course, when we talk about health financing, there is financing. And when there is financing, there is World Bank. So I would like to give the floor to Feng Zhao, who is a practice manager in global engagement of the World Bank in Washington, D.C.
Thank you. I'm excited to be here to support the launch of the Global Health Spending Report. I can say from my personal experience, I started my World Bank career 20 years ago to conduct the Public Expenditure Review, the PER, which is one core diagnostic instrument at the World Bank to guide our investment and to provide data for the government in Ethiopia. This is 20 years ago. I worked with an Ethiopian doctor by the name of Dr. Tetus at the time. So he's the head of WHO now. So I can tell you how important and impactful the spending data on the country's decision-making and also guiding the global financing aid. So I think this report is really filling in a major global gap, which is, in my view, the global PER, the global public expenditure review. So we need that data to guide our global effort and also guide country level decision making. So we all know money alone is not enough, but without the resources, it's impossible to achieve our goal. More importantly, is how we use the resources is a critical part of our investment plan. So this report has the critical data on where the global resources are located, which I can tell you, I will use it as my regular reference. I will go back from time to time for my daily work. So I cannot say enough the importance of this report. I'm glad the bank has contributed to this report. I'm seeing a few colleagues has been the co-authors in different chapters, and also our GFF colleagues has also contributed to this significant report. So we'll be happy to continue to work with WHO and other partners in the similar effort down the road. On the substance, I want to maybe share my reflections in the following 3 areas. The first one is investing in PHC is significantly featured. I still remember before the COVID, I was visiting Geneva, had a dinner with Dr. Xu Ke. I have really encouraged the team to take on PHC. We all know no UHC without PHC. Have data in this area is critical, not only to ensure the right investment on the essential services enjoyed by majority of the world population, but also with COVID, we have a new angle. Without a functional, robust, resilient PHC, it's very difficult for us to prevent and control a pandemic like COVID. So I'm really happy to see the report featured PHC. Now we have tangible and concrete data on the investment in PHC, which can be used for advocacy, for analytical, for financing purposes. I really appreciate that effort in that regard. The second one is really on COVID. We all know the COVID has significantly distorted our resource allocation for this year. But I want to highlight the thinking from a few colleagues in the World Bank. We were thinking this is the time, despite we focus on handling this pandemic, but it's also time to think about midterm system building and the long-term our health investment framework, because many soul searching are taking place, particularly from our colleagues at the Ministry of Finance and parliamentarians who are making the decisions on resource allocation. For us, investment in the hospital settings, strengthen ICU unit, buying ventilators are critically important, which has been a major part of the media coverage. But we're worried that will lead the misunderstanding of investment should towards to hospital, ICU unit and ventilators. The silent war, the quiet war we need to win is really the first tier is a functional, robust, resilient health system, which feature strong public health functions, surveillance functions, the connection to One Health agenda, connecting to human health, to animal health, environmental health, and feature them in our system, in our health system, particularly in PHC. So I feel those are critical areas for investment. I think this is the one message we can derive from the report and from our dialogue with Ministry of Finance and colleagues who are making decisions at the country level, particularly regarding to domestic resources. The second area for us to think about is really the the public health function, the core epidemiological tasks in terms of testing, contact tracing, lab capacity, human resources, which are trained to deal with the pandemic outbreaks. We can see experience from Korea. I'm glad colleague from Korea connected, and their experience in handling the pandemic in the early phase is really strengthening the public health functions and invest in testing and labs, which has play a critical role in managing the pandemic. My last point, my last reflection is on this golden trend I have observed for the past decades, is the growth in health spending is always outgrow the GDP growth. We have observed in the past decade has quite robust and not changed. But we have observed in 2018, and maybe for the first time in a couple of decades, GDP growth has exceeding health spending growth. So we can interpret it in many ways, but regarding to low-income countries, coupled with the data highlighted in the report, the low investment in health is really worrisome. We really need to make an effort and communicate clearly in that regard. The resources need to be put together, both domestic and the international financing, to support the core functions at the lower part of the system, including PHC, secondary care, and so on and so forth. The fungibility trend is also worrisome. We can see when the international financing picking up, we can see some decreasing of the domestic financing. So that really triggered questions on fungibility. Given the overall spending, I think it's critical for domestic spending and the international spending to complement and together to have a strategic direction to support the system and not one replace another. So that's another reflection I have. So let me stop here. So I wish everybody the best. I really, again, appreciate all the effort behind this report. This is truly a milestone report, which can really guide our effort globally and also at the country level. Let me stop here. Thank you.
Thank you very much, Feng. Also, thanks to the bank for the amazing work this year. I think you have supported so many countries and they all needed your help. So I think we owe the bank really a lot in this very special year. We will now move to the actual presentation of the report. And of course, this will be presented by the WHO Head of Unit of Health Financing, Joe Kutsin, together with our boss, Agnes Suka, who is the Director of Health Systems Governance and Financing Department.
Great, thanks, Claude, very much, and grateful if we can have the presentation on. Good, thanks. Well, I just wanted to thank, as Claude did, all of the speakers who came before for their kind words and recognizing the importance of this work. I'm doing this, and Agnes and I are doing this presentation really on behalf of our teams in health financing, in headquarters, and all the regional offices and country offices that contributed to this work. And as Claude mentioned, also to thank colleagues from the World Bank and GFF and also OECD who contributed to this report and have contributed over time to strengthening the quality of the data that is reported globally on health expenditures. So we have produced several of these reports, actually one each year for the past 4 years. And in a sense, some things are the same and some are different. All of the reports explore health spending data based on the Global Health Expenditure Database, containing estimates of expenditures in 190 member states going back to 2000. And the issue is really that actual expenditures get reported by governments and statistical agencies, typically with not less than or certainly not more than a 2-year time lag. And so the data is always, the current year -2. So the current database goes through 2018 from 2000. But of course, 2020, this would not be good enough. Yes, of course, the new database covers this period 2000 to 2018 with real country data, but there's no way to do a report and stay relevant in 2020 without reference to COVID. So we reached beyond our usual sources, drawing on information on budget allocations in 2020, specifically in reference to the crisis, and then also working with colleagues at the bank to draw on bank and IMF projections of the macroeconomic and fiscal implications of COVID, and really combining this with our knowledge of the determinants of health spending patterns from the historical data to reach some conclusions in this report. So we're going to start by first talking about the health expenditures before COVID, and this is again based on the Global Health Expenditure Database. Really, we can look at this two ways. One is in the aggregate of global health spending, as you can see here, and the other in a moment looking at countries as the unit of analysis. So here, this just gives you an idea of what global health expenditure was, everything converted into US dollar terms in 2018. And you can see that it's very large and very domestic, with external aid, and you can see that tiny little dot being a very small share in the aggregate of global health spending. And staying on this theme of looking at the overall distribution of health spending in the world, it's clearly very concentrated in higher income countries. And that should not come as a surprise, although it is still quite remarkable, especially given that one country in particular, with about 4% of the world's population, accounts for over 40% of global health spending. And it's a reminder of our common saying that you can't simply spend your way to universal coverage. So this is now looking more at looking at data, taking countries as the unit of analysis. So really based on averages of country shares in each income group. And this is capturing some major patterns of the past few decades. Certainly on the revenue side, what we tend to see is higher income countries tend to be more public in their financing mix, lower income countries more private. We see out-of-pocket spending, or OOPS, which many people know is one of our favorite health financing acronyms. OOPS are persistently high in low income and lower middle income countries. The share is falling, but still high. Aid has grown, external assistance in green there has grown in low income countries and then sort of stagnated a bit in the last few years. And so this is also the case that in lower income countries, low income countries, that the government share of spending has declined until about 2015. Now, very often we talk about health spending in terms of percentage shares. Right, that, and the idea that we try to bring out-of-pocket payments below a certain percentage of total health spending. But this slide tries to make clear that we need to think beyond those percentage shares. So this is really looking at the rate of growth of out-of-pocket spending on the horizontal axis and the rate of growth in public spending on health on the vertical axis. And this is showing over this period of 2000 to 2018. And what we see is the overwhelming majority of countries are in that upper right quadrant, which means that basically government health spending and out-of-pocket spending are growing. If they're in the blue part, it means that, for example, government spending on health grew faster than out-of-pocket, but it does not, and so in a way, in those countries, we would see the share of out-of-pocket falling relative to government, but it does not automatically mean that fewer people are at risk from out-of-pocket payments, right? So this is really why we have to monitor, as we do, the extent of catastrophic and impoverishing payments based on household surveys. Another thing we have observed historically, and in our more detailed health accounts work, we were able to construct estimates of health spending by disease group in about 40 low and middle income countries, working very closely with health ministries and central statistical offices and then applying a standard methodology to ensure consistency and comparability. What we know is that some of the data by disease are available very directly from health programs oriented to that disease, while other data have to be attributed from overall health expenditures. And the methods for this are described in the report. But just to say that it's a very labor-intensive and data-intensive process to construct these estimates. Now, these figures cover 2016 to 2018, and the point and the summary message here is when we look at it, that overall aid certainly matters more in lower income countries than middle income countries, and especially aid is targeted, again, as we would expect, at more infectious diseases, whereas non-communicable diseases tend to be more domestically funded, both in lower income countries and middle income countries. I should say that before going further, what we're doing here is really just a snapshot of some of the key findings of this report. And so there's a lot more to it. And those of you who know me know how challenging it is to keep it brief, but I'll do my best. So we went through some of the historical spending now to look at the situation in a set of countries that are both low-income countries and lower middle-income countries that really experienced very little economic growth over the 2 decades prior to 2020. In this graph, what we see on the vertical axis is service coverage according to the UHC indicator 3.8.1 on service coverage. And that is very clearly linked to country income. And on the horizontal axis is financial protection. So or actually not, it's the incidence of catastrophic expenditure. And in a way, the further to the left you are, the better off you are in that sense. So what we see is that in the lower income countries, which are in orange, they tend to have low service use. So that's a real problem. Many of them do have low catastrophic expenditure, but that is really an artifact of their low service use. And it's worth sometimes saying that out-of-pocket payments only occur when people use services. So these are broad country averages and raise a lot of concerns for this group of countries. What we don't see here, and is very much a concern, is that these are country averages. So here we do not see inequalities within countries. That really requires looking at country-specific data, but we certainly know that in many and perhaps most cases, these are quite large. Another concern that we have for these countries is that as aid grew from about 2000 to 2014, which is the bars, the height of the sum of those two, the green and the lighter bars, is total aid. We see the priority that governments gave to health from their domestic spending fell. And so this is a cause for concern if indeed we are seeing this phenomenon of fungibility, that governments are allocating away from health in response to health aid. And so really needing to think about whether and how to rethink aid in ways that are more additional. And the last thing I'll say, and this is really important in looking at the data, and we haven't looked at this very explicitly. We know when we talk a lot about the need of governments to reprioritize in favor of the health sector, but governments have many priorities and responsibilities, and it's not always easily achieved. And here you can see the shares not only for health, but for education, for the military, and for debt service. And what I've highlighted in the top right, and to leave you with this concern, is that in 2018, average share of government spending on health and the average share of government spending devoted to debt service in lower income countries was the same. So this is really a concern and will be a concern going into the COVID era. And with that, I'll stop and turn over to Agnes.
Thank you very much, Joe. So Joe presented in a few slides a panorama of where we were in 2018 and where we were before COVID-19 hit the world. And in many ways, we had made a lot of progress over the two decades that preceded 2020. But much of this progress now is questioned because the COVID-19 health-related crisis, that is both a health crisis and an economic crisis, has revealed a lot of weaknesses. And as Ilona said at the beginning, the feet of clay of our national and global health financing architecture. So of course, national health accounts and the global database on health expenditures provide us country-based verified data only at N+2, that is 2 years after the spending occurs. So it's not easy for us to get information on what is actually happening real time in 2020, because we do not have the results of national health accounts exercises, and we don't have actuals in terms of spending, if only because in many countries the fiscal year is not even over. So we use different methods to be able to approach the real life situation in 2020 using mostly budget data, not expenditure, not actual spending data, and trying to work with countries, so surveying countries, exchanging with countries, using our institutional capacity, both in WHO with our regional offices and country offices, but also partnering with the World Bank and the IMF and using their capacity at country level for dialogue so that we would have a sense of what is happening. And here are the early findings of this exercise. First, we can see that the health response to the COVID-19 pandemic is already reflected in budgets. We know there has been a very strong fiscal response to the crisis. And here we have actually data for a series of countries that are both in the high income, middle income, and low income categories. And through this data, we are able to see what is the share of public allocation that was dedicated to COVID according to what these countries have included in their budget laws and in their revised 2020 budget. And what we find is that actually significant amounts have been allocated to the response. But within those significant amounts, the amounts that go to health, to the health sector, are actually quite small. The largest amounts actually go to the stimulus and the response to the economic crisis by providing cash transfers and other safety net measures, as well as support in terms of both grants and credit lines to small and middle-sized enterprises. But when it comes to health per se, what we found is that in high-income countries, there was about 8% of what was the previous spending on health of these countries that was allocated to the response to COVID-19. In middle-income countries, it was slightly higher, close to 13%. Countries, it's a very large proportion of previous health spending that was allocated to COVID, actually more than 36%. So while generally higher income countries have been hit most violently by the pandemic in terms of number of cases, the poor countries actually had a larger proportional fiscal impact when it came to increase in health spending. We need to say here that these are budgets, it's not spending. So the jury is still out there. We also don't know whether these amounts that were allocated, that were budgeted for the COVID-19 response are actually additional to the spending that was done in 2018, 2019, or whether it is a combination of additional and reallocation. This is what we will need to further explore next year and the following year. What makes it difficult to assess the impact of COVID-19 on health spending is the fact that forces go in different directions. They're both forces that put upward pressure on health spending and forces that put downward pressure on spending. So on upward pressure, obviously the need for the response, the additional activities for data, for testing, for tracing, for responding, for public health measures, is an upward pressure, but also the consequences of foregone care when people cannot access care and have to use other ways or have to delay care, and then it becomes more costly. The maintenance of essential health services at a time where there is pressure on demand for services. So we find that many countries found that their services became overwhelmed and they had to increase the resources to be able to respond to this additional utilization that came from the additional demand. Necessity to invest in system preparedness to respond to this crisis, but also the realization that there is a need to invest more in common goods for health, in essential public health function and epidemic preparedness, but also addressing better the environmental threats and risks, such as the risk to biodiversity or climate change. And of course, right now, the upward pressure on the COVID-19 vaccine rollout, in which massive amounts of funding are needed to fund both the vaccine itself as well as its deployment. But we also need to be fully aware that there are also downward pressure on health spending. First and foremost, of course, is the economic contraction. The latest estimate of the IMF for 2020 talks about a global decrease of global GDP by 4.4%, which is several trillion dollars of economic contraction, so loss of economic output. There is also decreasing foreign direct investment, this decreasing trade and remittances, increasing unemployment. Can you go back? Increasing unemployment, increasing poverty, falling government's revenue that are related to both the economic contraction, but also potential unemployment. So people not being able to pay, as people and companies not paying as many taxes as in 2018 or 2019. The increase of debt service obligations and the need to borrow that is required for counter-cyclical policies and stimulus, but also the potential tightening of external financing, and has already been signs from some countries that aid flows might further decrease, although they were already on the decline before the crisis. And downward pressure, we've seen foregone care, and that has been well documented, particularly in Asia. The crisis has often led to less utilization from other services than the COVID-19 services, leading actually hospitals to have less activity, but mostly less revenue coming from both public reimbursements from either social insurance or national health system, and also foregone fees coming from different sources. So how this upward and downward pressure will play on average will actually be probably very different depending on the country. And because of the institutional context, the particularly economic context, the nature of the to the impact of the crisis on trade, on tourism, also the impact on unemployment. So we will need to be able to be assessing the situation in every country. We already know that there will be significant macroeconomic impact of the crisis that will automatically play on health spending. First is the already high debt levels that were looming before the crisis will increase as a result of the crisis. Following debt relief and the HIPC movement between 2000 and 2010, both the stocks and the payments of debts of low-income countries and low-middle-income countries had dramatically declined. But before the COVID-19 response, we could see that this debt level had started to increase again, partially linked to the response to the 2008 global financial crisis. What we expect is, because of the necessary stimulus and Keynesian counter-cyclical policies, is for this debt level to increase significantly in 2020 and after 2020, to be able to respond to the crisis, not only for the health sector, but for all sectors, particularly investing in cash transfers, social safety nets, and different ways of support small and middle-sized enterprises and other businesses, so that to ensure that employment is not too affected and unemployment doesn't rise too much. What we know also, and this is what our colleagues from the World Bank have calculated, is that it's very likely that the COVID-19 economic crisis linked to the health crisis will link for the first time to a slowing down and potentially, according to their estimates, to their calculations, an increase of poverty for the first time in several decades. So the trend that we had been observing since 2000 of continuous and rapid poverty decline is likely to be interrupted, and poverty will not be falling as fast as it used to be, and some gains might actually be reversed. And as we know that the service coverage and the financial protection indicators are very intimately linked with economic growth and with poverty reduction, it is to be expected that our progress on health coverage, as well as a progress on health financing, might also be slowed down and potentially reversed. What is particularly important is really to think about those countries which had pre-crisis vulnerabilities. In fact, we have this group of countries which were in a way left behind, these low-income or low-growth countries which really have stayed over the past 2 decades in a low-income trap, with very small increase of domestic revenue, large increase of aid, but much of this aid being actually fungible and leading to crowding out public spending, and stubbornly high levels of out-pocket spendings. So in this particular case, we should really be concerned and about those countries in the upper quadrant here, which are countries which have both low per capita economic growth in 2020 because they were hit by the crisis, and had at the same time a pre-existing condition of very high out-of-pocket spending. With low growth, low tax revenue, and high pre-existing out-of-pocket spending, those countries are probably the most vulnerable when countries will need particular attention from both national and global policy makers for adjusting in order for them to adjust their public policies to protect people from the increase in poverty, from the impoverishing aspect, the impoverishing consequences of health utilization, but also potentially from decrease in access to services, either because of financial reasons or other reasons linked to the pandemic, of COVID-19. So in summary, and as we're reaching the end of this short presentation, before COVID-19, by December 2019, we were on a very positive trajectory towards universal health coverage and towards the health SDGs to be achieved by 2030, which is the commitment of the global community. There was an overall growth and quite rapid growth of health spending, But we were on a diverging path. On one hand, service coverage was improving, coverage, but on the other hand, financial protection was not. Too many countries and too many people were being left behind. Then COVID hit. And we are now living in a world in which underlying weaknesses of country and global health financing systems have been revealed by the crisis. We've seen that in 2020, there has been a massive health and other health spending and other public spending response that try to address these underlying weaknesses, whether it was the high level of out-pocket spending, the high reliance on labor tax to fund social health insurance, and that proved to be a problem when people lost their jobs and couldn't access services at the time of crisis, and other fragilities such as, for example, the fungibility aspect of aid. We know that there are pre-existing fragilities. They were there already in 2019. But these pre-existing fragilities have been made not only obvious by the crisis, but they've been made worse. And these pre-existing fragilities pose risks for both health security and UHE and the achievement of the SDGs. So we need a proactive policy response. So the report next comes with a series of 6 recommendations for a new health financing compact in a COVID-19 world. These 6 recommendations are the following. First, secure domestic public spending for health, because health is both a societal and an economic priority. There is no need to do any investment case for health anymore. The year 2020 is just the ultimate proof that investing in health is good for people, it's good for the economy. Second, we need to fund the public health priorities, the common goods for health, as the step 0 of universal health coverage at country level. These are the fundamental functions, the programmatic functions that can be funded only collectively through a collective purse, because one cannot charge huge fees. These are the public goods and the functions for which there are large market failures. They are the population-based functions or the essential public health functions. Third, we need not only to invest in common goods for health at country level, but we need a new framework to ensure the sustainable financing of global common goods for health to enable global health security. Fourth, we need to prioritize public funding to ensure the equity of access and the financial protection through a primary healthcare approach, so that we ensure that everybody on the planet has access to basic services, including those today in rural and peri-urban areas that don't even have access to the most basic care, including a qualified health worker and a clinic with water and electricity. Fifth, increase the level of aid to low-income countries. Aid for health has declined over the past few years, but we need to change the way we provide aid. We need to adjust aid modalities so that we reduce the fungibility effect, which has reduced the impact of aid on health funding. And finally, fund national institutions so that we invest in the institutions to track health spending at both country and global level. Thank you very much. I really want to thank all the partners who have helped us with this, the Health Accounts Consortium of Investors and other global and regional partners supporting the Global Health Expenditure Database. We are incredibly grateful to all of you. This report and this global public good would not be possible without your support and your funding. We also we want to thank the technical agencies that have helped us, the academics and the individual experts, with a special thanks to the World Bank and the IMF for their incredible collaboration. And we really also want to give a special recognition to civil society organizations in the general public and how they are promoting and use these data to advance the cause of UHE and provide evidence-based numbers for discussions and budget watchdog and parliamentarian dialogue. WHO remains firmly committed to the continuous improvement of this global public good. Thank you.
Thank you very much, Agnes. Thanks for those very powerful insights, both Joe and Agnes, as well as the whole team that is behind Shuke and all the colleagues in the department. I will introduce the first block of panelists that will react to the report. And this is the country perspective. And we will start with the academic point of view. The floor is yours, Sunman Kwon, professor in the School of Public Health in Seoul National University.
First of all, big congratulations on this excellent report that provides us with a lot of important information with lots of policy implications. Among many issues examined in the report, I'd like to make some brief comments on the unmet need and equity issues during the pandemic. As you can see in the report, many countries, there are evidence of reduced overall out-of-pocket payments in the total healthcare spending. I mean, in ordinary times, the reduction in out-of-pocket payment should be a good news, but it is not a good news in many countries, because there is a reduction in out-of-pocket payments mainly because of the unmet need. So this unmet need will be the long-term cost and burden on our healthcare system, both from efficiency perspective and also equity perspective. And there are many possible pathways, regions, why there are high level of unmet need. Obviously, one pathway is that because of this pandemic, decline in income, unemployment, or absence of insurance coverage, things like that. But there are also non-financial pathways or regions for this unmet need. For example, many countries are focusing exclusively on this COVID-19 response. So there's a crowding out by this COVID-19 and at the sacrifice of other essential services. And also when there is a severe lockdown, people cannot get access to care. And another reason, for example, in the case of Korea, there's fear, okay? Especially at the first half of the year, there's a sharp decline in the healthcare utilization, mainly because the people are scared of being infected. So they're scared of visiting hospitals. And of course, some of them maybe unnecessary care forgone, like because of this personal hygiene, there is a decline in the utilization of services for ear, nose, and throats. But there might be other forgone essential healthcare. For example, some cancer patients gave up visiting healthcare facilities. So this type of unmet need have a very clear equity implications, because this unmet need may occur differently for different population groups. So we need more research, like in Korea, we need more research on the nature of this potential unmet need or excess mortality or excess burden. And also related issues of equity. I think in many countries, including Korea, those who suffered a lot during this pandemic are the poor, elderly, and vulnerable population. So I think this equity issue is a clear, important implication, not only within country, and also across country at the global level. So in that sense, I think we should really think twice when government implemented a policy on social distancing, because the government should consider not only the issue of saving lives, but also saving livelihood. Because when there is a severe government measures, it affects mainly the poor and vulnerable part of the population. In Korea, the macroeconomic indicators looks okay. I mean, among OECD countries, Korea has been experiencing a smallest negative growth in a sense compared to other countries. But if you look at this picture in more detail, there are many potential problems, because like a big business, Samsung, Hyundai, they are doing good, and people, during this pandemic, middle and the high income household are not severely affected. So the sales of cars and sales of a big ticket electronic items, mobile phones are very high during this pandemic. And the stock price is going up for this big business. So big business are prospering at the expense of small business and self-employed. So, I would like to emphasize that we really should care about these equity implications. And also from the perspective of healthcare utilization and spending, we should not forget the potential issues of unmet need as a result of this during this pandemic. Next issue is governance. We all know that the multi-sectoral approach is the key, and especially as an effective response to COVID-19, the collaboration between Ministry of Health and Ministry of Finance and other healthcare financing agencies is quite important. In Korea, in principle, the cost of treatment of this infectious disease should be funded by government budget, even though we have a universal coverage national health insurance system. But because Ministry of Finance has to provide a lot of funding as a rescue fund, as a safety net and revitalization of the economy from the very beginning, contrary to the principle of funding. But the major treatment cost, major part of the cost of treatment of COVID-19 was funded through national health insurance. And government budget funded the out-of-pocket payment, co-payment part. So basically it's free, 100% free for the patient of COVID-19. But this type of rearrangement of the responsibilities of the funding, I think it was effective, at least in the case of Korea. And also Ministry of Finance, I hope they realize the importance of the health and economy nexus. And also in that sense, Korea had a very, a bit painful experience, but it paid off experience from the MERS, Middle East Respiratory Syndrome experience 5 years ago. So after that MERS experience, government of Korea or Ministry of Finance supported the huge investment in the pandemic preparedness. Basically, this investment in the common goods for health, like strengthening the Korea Centers for Disease Control, its budget, personnel, its capacity. And this investment in common goods for health gave us the return, in a sense, for this pandemic, in terms of that we avoided the surge of patients. And as a result, so far, not too bad. We have many problems as well, but still, this pandemic has not had a huge negative impact on the healthcare financing, mainly because we managed it to, the number of patients or confirmed positive cases at a reasonable level. And then finally, I think as you know, from the Korean experience or from the global experience, I think that in terms of healthcare financing system, flexibility, reprioritization, reprogramming capacity of this healthcare financing or the purchasing capacity is quite important. And also in terms of those key issues examined by this report, I think primary healthcare is so important. And in that sense, Korea would have done better than now if we had had a stronger primary healthcare system, but Korean healthcare is very much of a hospital-centric care. So although we have done so far so okay, but the social cost would have been lower if Korea had a stronger primary healthcare system. Okay, this is the end of my comments. Thank you.
Thank you very much, Sunman. The second country perspective is going to come from Africa, from Kenya. It is the Deputy Minister of Health of Kenya, Dr. Mwangangi. The floor is yours.
Thank you so much for giving me this opportunity to share with you Kenya's experience. And let me begin by appreciating the great work that has gone into coming together with this report. This report is indeed edifying, and it provides for us as a country a platform to reflect on, health expenditure and to perhaps, weather the storm and go beyond the storm. So thank you so much to the WHO team for this report. Now, in terms of my reflections, I did go through the report, and I wanted to frame them from the 6 recommendations that have been shared with us by Agnes. She's been able to take us through the key findings in terms of public health expenditure, its relationship with all the different variables that we're experiencing right now. And so I looked at the recommendations, and I'll be able to share with you some of the experiences that we've had in Kenya, what we feel would be the way forward, particularly in the implementation of these recommendations. The first 2 recommendations are tied on to ensuring that we're increasing expenditure towards health and funding common goods, perhaps is the most fundamental lesson we could all pick from the COVID-19 pandemic. And indeed, as a country, we've been able to demonstrate that investments are very useful when it comes to health security and surveillance systems. And you could see perhaps a play-by-play of the script that immediately we were hit with the COVID-19 pandemic. We immediately, reappropriated resources towards setting up lab systems, surveillance systems. And I think on reflection, 9 months later on, one as leadership teams within the Ministry of Health, but also at the cabinet level with the Ministry of Finance, one of the important things that we all agree upon right now is that we must be able to finance the common goods, and that this is indeed a stepping stone. Now, I do take note that the report termed this as the 0 step to UHC. I have a little bit of an opinion, a different opinion, that perhaps this could be the foundational step of UHC. In Kenya, in terms of supporting common goods and trying to finance them, we were able to really put in place, resources that touched on all the various building blocks, and I'll call them the WHO building blocks of the health system. And so as we were procuring equipment for lab systems, we went ahead and hired new human resources for health. We went ahead and reviewed our surveillance infrastructure to ensure that it is available and is responsive. This meant, therefore, investments in health information systems. This meant investments in ensuring that service delivery is actually robust when it comes to dealing with the COVID-19 pandemic. And what we foresee as a country, particularly in terms of trying to consolidate these investments and going forward, is that it becomes very important, one, to always have structures for financing, should I say, pandemics, and structures that are able to perhaps come in with an effect of filling in the short-term gaps as you work onto the medium-term and long-term frameworks. But this must not necessarily be linear, in the way of thinking that this is what we're going to do in the short term and then jump onto the medium term. In fact, in Kenya, we've seen processes where we've had overlapping timelines. Some of the investments we have in our lab infrastructure will soon be absorbed into what we're calling Kenya CDC, which is essentially an institution that is thought to provide a proper framework and structure of dealing with public health emergencies. And so really, we do support the key recommendation of the report that you must fund common goods for health as a 0 step to UHC. And additionally, as a country, perhaps before I get to the next recommendation, we've gone ahead and identified other nascent services that we feel, are foundational and perhaps would be classified as common goods in Kenya. And that is emergency medical services. And so as we roll out, our KCDC, we are also putting up together what is known as an EMS system that will then be able to, provide these services and perhaps form part of the, benefit package for UHC services within the country. The third recommendation concerning domestic funding and public spending and increasing resources is perhaps one, that we've often, spoken about and we've championed, at the global level, at country level, at county level, seeing that Kenya is a devolved country that has autonomous agencies, across the country, about 47 of them managing health systems. And indeed, while this remains a spirit to ensure that, there's increased domestic funding, increased public spending in health, it becomes, again, of course, important to appreciate the current backdrop of COVID-19. And I think the presenters have been able to share, their projections as to how we'll have detrimental effects when it comes to country GDPs, and therefore, of course, the resource basket that is available for public financing. However, I must say Kenya perhaps, is a country that is also going through a constitutional reform process that promises to have more resources coming into the health sector. We are in the process of building bridges initiative, and part of this process, while largely political, also actually touches on the spending when it comes to county governments. And one of the key proposals is that we want to increase financing from 15% in terms of the total government spending and have 35% of that allocated to county governments. So as a country, and particularly as a Ministry of Health, we are well aware that should this process go forward, then the Ministry of Health needs to be very alert, needs to be very agile to collaborate with county governments to ensure that this increase, this almost impending increase in resources at county level actually translates to also an increase in health spending at the county level. And we've seen different initiatives in terms of, health actually having, a weighted score when it comes to revenue allocation formulas. Kenya most recently completed its third cycle of its revenue allocation formula within the country. And for the first time ever, health was actually a weighted variable in that resource allocation formula. And it will be interesting to see when this is now effected in the coming year, what that will translate to for health. And so again, yes, domestic funding should be championed against the backdrop of the current constraints that we face. But as a country, and Kenya particularly, with the developments that are currently underway, we are optimistic that with the constitutional reform process, as well as the new revenue allocation formula, we will be able to have more resources going to health within the country. When we look at the fourth recommendation from the report, it talks about prioritizing public funding and ensuring equity of access and financial protection. Kenya, perhaps again, an interesting story to tell here. Again, one agreeing with the report findings that yes, indeed, our out-of-pocket expenditure has remained high and it's persistent. And then of course, that would mean that we're not exactly hitting the ball when it comes to financial protection. And then my colleague from Korea mentioned that sometimes you would think that, with increased resources allocated, that this would have an effect on reducing out-of-pocket expenditure. And again, this situation has been evidenced in Kenya. And so what we are doing in terms of deliberate intentional steps as a country is we are in the process of developing regulations for what we call the UHC fund. And it is through this fund, we hope to actually enshrine the very principle of equity to ensure that poor and vulnerable households, marginalized communities are able to get services and are able to ensure, and we are able to ensure that one, they do participate even in the resource basket when it comes to sharing out the resources, but also accessing the services. And we do strongly feel that this is one of the key processes that will perhaps ensure some form of ring fencing. I know it's not a popular word, but some form of ring fencing for resources to the health sector within the country. And so this is a step that is in its last, weeks in the country. And we'll be moving this UHC fund to our parliamentary spaces for legislation to, then follow suit in terms of setting up this fund. I think it also becomes important to also examine the different country responses when it comes to COVID-19, particularly with a frame of equity. In Kenya, we have seen, different experiences in different counties. Even if, the resource basket for COVID-19 was more or less shared out equally within counties who have autonomy in the spending of these resources, we've seen different county governments invest in different ways. And sometimes this has led to an effect when it comes to the equity and in access of these services. And so it becomes important then perhaps also, as we set up this UHC fund, to really put in deliberate measures that actually facilitate equity in access. And this is part of what we are working on within the country. And then when we look at the issue of ensuring that we actually have this data available and that, the data is actually able to inform decision-making, it becomes then, of course, very important to read this report and reflect on it. We've been able to discuss the report in terms of our leadership people, within the Ministry of Health. And it's important to learn that when you're dealing with a pandemic, sometimes it becomes perhaps very instrumental to have, a comprehensive view of the different, resource interventions that you've put in place. I do remember perhaps 2-3 months into the COVID-19 pandemic, having a team go to the ground to do assessments in terms of availability of different forms of equipment, only to realize that this had been done, perhaps 3 months prior to that. And so there's definitely a need for visibility and having systems that are actually able to, give you almost real-time data when it comes to expenditure. And again, perhaps lessons learned from Kenya through the COVID-19 pandemic. We've since improved our procurement systems, particularly for medicines and commodities. And now there's visibility in terms of the resources that we are putting in. And then, of course, we're able to then follow those resources and to ensure that they do actually lead to good health outcomes. The other key element then becomes perhaps what everyone has talked about, being very deliberate. How do we weather this storm? How do we move beyond the storm? How do we then, see the sun beyond this storm? And therefore, in agreement with everyone who's come before me, that we must be deliberate when it comes to our health financing policy interventions. And we are being deliberate within the country. Like I mentioned, we are putting together what we're calling a UHC fund. We're putting together the KCDC institution, which will aim to perhaps galvanize efforts when it comes to health security, public health emergencies, and their management. And then, of course, going forward, we have actually gone ahead and reformed our National Hospital Insurance Fund. There is an amendment bill in play right now that actually, for the first time, recognizes the UHC scheme within the country. And so we do feel as a country that COVID-19 has indeed been a silver lining. It has recalibrated our thoughts. It's definitely given us a reset to, remind us that UHC perhaps is the center of this all and forms the, the platform for us to be able to then, of course, manage public health emergencies, but also ensure continuity of services in all the different service intervention points that we have. So thank you so much, WHO, for this report. It really does form, a very important resource document for reflection. And perhaps my last point then would be in governance. I think the COVID-19 pandemic has, taught us that governance and the structures of governance are so very important when it comes to making some of these deliberate, interventions in health financing. In Kenya, some of the decisions that we've made today, setting up a UHC fund, setting up Kenya CDC, setting up all this infrastructure have been guided by the governance structures that we put in place to fight COVID-19 pandemic. And so perhaps the next report can shine a light on how governance and leadership interfaces with resourcing the health financing space. So thank you, and over to you.
Thank you, Dr. Mwangangi. We are going to move now to the last perspective from the civil society, and I would like to give the floor to Lenio Kapsaskis, that is the head of health policy at Save the Children UK.
Thank you very much. And just to say how useful and valuable this report and its predecessors are for us at Save the Children as well. So in the next few minutes, I'd like to talk quickly, I promise, about how important it is that public financing for health systems prioritize the most vulnerable, and that it's not just about how much money is spent, but how it's spent to reduce inequities. I also want to highlight the hugely important role communities play in holding governments to account on commitments to health financing. And thirdly, just how important data such as this available in the Global Health Expenditure Database is for advocacy and accountability. As civil society, we need to be able to access and use high quality and timely data to ensure that resources are really being spent to achieve health for all. So despite the pledge to leave no one behind, large inequalities remain in many health outcomes between children growing up in more advantaged households and the most deprived and marginalized children. Among the poorest children, death rates average twice those of the richest. In too many countries, as we've seen over the years from the data, people are still picking up the bill for their healthcare, pushing them further into poverty. We've seen in the Global Health Expenditure Report that in lower income countries, nearly 60% of domestic spend on health was out of pocket. This feels more urgent than ever before, considering the huge impact COVID has had on family finances. Save the Children and UNICEF calculated that prior to the pandemic, nearly a third of all children in low and middle income countries were living in families who couldn't make ends meet. Projections for 2020 and 2021 are set to be even bleaker. According to the findings from the recent UHC State of the Commitment report produced by UHC 2030, almost half the survey respondents reported that there has been no change, except sometimes an actual increase in user charges during the COVID-19 pandemic. We welcome the WHO's call to remove user fees for all services during the pandemic, but we continue to make the case that this needs to go further. We've been hearing a lot about effective, efficient financing and improved public financial management over the last few months. These are all hugely important and will continue to be in light of the current situation. But equitable allocation of resources needs to remain front and center of any decision making. At Save the Children, we worked with UNICEF to see just how much public spending on social services benefits poor and vulnerable groups. Our data show that in countries such as Colombia, Ghana, Indonesia, and Mexico, the proportion of public spending on health for poor is below the poverty headcount, meaning actually that the poorest group of society have a disproportionately small claim on public resources for health. So what about accountability? We've seen that countries with higher government spend on health have lower under 5 mortality rates, but there are also a lot of differences between countries with the same levels of investment, implying that financial resources for health are important, but aren't the whole picture. Civil society, children, and communities play a critical role here in demanding quality health services, ensuring health allocations really prioritize their needs. Accountability is about ensuring decision makers honor their commitments and obligations, demanding that their investments translate into tangible results, and insisting that they be transparent about what works and doesn't. To this end, our analysis in our briefing launching tomorrow for Universal Health Coverage Day shows a strong association between civic space and health spend. Countries with open civic space, where communities are able to come together and organize freely, tend to allocate more resources to health. Countries where civic space is narrow or non-existent tend to invest less in health. To be held accountable, governments must be transparent and share information on policy formulation, health planning, and budgeting, and they need to engage communities in monitoring how effectively the budget is used. On inclusion, the findings of UHC 2030 State of the Commitment report are clear. An equitable response to COVID-19, and I'll extend this to UHC more widely, requires that civil society has a strong role, and that communities most likely to be left behind are given a voice and a seat at the table. This also highlights the hugely important need for consultation and qualitative data to accompany quantitative findings and reports such as the one we've heard about today. For civil society, the availability of easy to use, reliable, and accessible data is central to being able to do our work. It's at the heart of the political nature of universal health coverage. So, we need governments and donors to protect the health and well-being of a generation of children by increasing investments and support for strong and resilient health systems, including removing financial barriers to access. But we need to think not only about how much money is being spent, but who it's being spent on and how this can be tracked by civil society and communities. It's in all our interest as UHC champions to rally together and develop strategies that will expand and protect civic space to promote social accountability on spend and prioritization. Thank you.
Thank you very much. Now I can also use my little power as we have a recorded message from Anuradha Gupta from Gavi.
Good morning, good afternoon, everyone. It is such a pleasure to see the launch of a global report on health spending. We are very pleased because we contribute to the preparation of this report, particularly on compilation of immunization expenditure data. At Gavi, we also use the findings of the report to adjust and adapt our policies and strategic approaches to strengthening country ownership and sustainable financing in countries, which is so core to Gavi model. This time, I was very impressed with the wealth of information that this report yields, as always. But I would really want to focus on three key messages that, for me, stood out in particular from this report. Now, the first message, which is disappointing, is the finding that though public spending on health is increasing, it is increasing rather slowly compared to the rise in GDP. In low-income countries, in particular, we see continued dependence on donor funding, and that is something that is important to the financiers from the perspective of thinking about investing more in political advocacy to make sure that countries are encouraged to spend more in primary health care, including in prevention, such as immunization. We do work a lot with countries, and in the past, we have seen some very encouraging trends on sustainable financing for immunization. Just before COVID-19, in 65% of Gavi-supported countries, we had seen an encouraging increase in domestic budgets for routine immunization, which included costs relating to delivery. The co-financing that countries have to put on the table towards vaccines was improving. Countries were able to make co-financing in a timely manner. But of course, COVID-19 has created exceptional fiscal strain and stress in countries. So it is going to be important for Gavi and all other international institutions to continue to support countries to protect domestic budgets for primary health care and essential interventions such as immunization and several other services that are needed for women, children, newborns, and adolescents. The second message that comes out very strongly in the report is about macroeconomic vulnerabilities in lower income countries, deepening poverty and inequities. And I do think that's a very important challenge for all of us to pay attention to. At Gavi, as we move forward, we are becoming increasingly focused on inequities within countries. We know that COVID-19 has further exacerbated inequities, have pushed millions more into deeper poverty. And unless we work with country governments to bring a very sharp focus on inequities in access to health services, we are going to see disproportionate burden of morbidity and mortality among poor populations. I was also very concerned to see that out-of-pocket expenditures in low-income countries actually haven't gone down at all. And we all know that high out-of-pocket expenditures would mean that poor populations and poor households have to actually bear the burden of medical catastrophic expenditures, and which really pushes them deeper into extreme poverty. So something to pay attention to. And the last thing which I thought offered a glimmer of hope to all of us is this whole clarion call to rebuild better. COVID-19 is teaching us new lessons. We are seeing a lot of innovation and ingenuity across countries, even in countries that have low incomes and suffer from deep poverty. And this is the time for us as a global community to come together and support countries to rebuild better, to work towards a more efficient, more resilient health system, something that the report emphasizes, that countries are paying attention to specific diseases, but they do need to pay greater attention to building resilient, efficient, effective health systems and delivery focused on vulnerable, marginalized populations.
The next to speak, and that represents global investor in UHC and health financing is Jean Kagoubare from the Bill and Melinda Gates Foundation. Jean, over to you.
Thanks, Claude, and also really thanks for WHO for inviting the foundation for us to say a few words. And I know the time is up. I will try to be really brief. First of all, this is certainly a major accomplishment in a year which has been so challenging, also uncharted. And we would like to thank and congratulate the team for this hardworking, from both the headquarters in Geneva to regional country level, and also, most importantly, the country teams that have contributed to this effort. We now have, as we saw, estimate spending for 190 countries, and most of them actually for several years. And this year, particularly, we also saw that we were being innovative and were able to have an initial estimate for COVID-related spending using, I would say, very innovative methodology, and hope we could do the same in the future. And as we know, so for now several years, WHO actually began working with countries and partners to develop a methodology for estimating PHE expenditures. And we are really glad to see that more than 50 countries are producing these estimates year after year. And one really notable thing that we want to continue to stress is the Global Health Expenditure Database, which has become a real valuable public goods. And for that very reason, we have been supporting and will continue to support this effort. The breadth and now even the depth of the data and information is really growing and being used quite extensively. As you all know from our foundation perspective, if you don't measure something, you can't fix it. So having health and PHE spending data is really vital to mitigate, particularly the out-of-pocket spending that we saw, which continue to be persistently high and remains, particularly for the low and the middle-income countries, above 40% of the total spending. And this is really a concern that can still, precipitate people in a medical impoverishment. And we are here certainly today to really congratulate the team. We also would like to have more to do in the future, particularly in areas of new methodology development for the system of account, improving the quality of estimates in the countries, supporting countries to sustain expenditure tracking work and be able to have a real-time data so that they can actually have use the result for policy making decisions, prioritizations, and also, frankly, given the fiscal constraint, we saw try to really spend enough, but also spend well so that they can actually get more from the money they are using. And lastly, just wanted to commit and affirm our commitment to continue to support WHO and the partners to continue this health expenditure tracking, both at the country, but also at the global level. And we are looking forward to our continued collaboration with our partners and also with WHO in the coming years. So let me stop here, and again, congratulations for this report. Over.
Thanks a lot, Jean. We move straight to the next global investor, and I would like to give the floor to Matthias Reinecke, who is external advisor to the European Commission on Health.
Thank you very much, Claude, and I join all colleagues in praising WHO for this timely release of this report. This is very important for EU, and it is particularly timely as the EU is now preparing for its new programming for the next 7-year cycles at global and at country level. This happens, of course, as we have talked now, under the massive impact of the COVID-19 pandemic. And one of the strategic decisions coming out of the situation the EU has taken is for the new program to launch the Team Europe initiative, whereby the EU and its member states want to ensure that through a very close cooperation and coordination between their respective country programs, including health programs, we will be able to achieve the best synergies and effectiveness of funding in strengthening the economies of these countries and also in their health systems. In response to the COVID-19 pandemic, you know this, our President von der Leyen, in close collaboration with WHO, had started the pledging marathon in spring this year, which resulted in a pledge of more than 15 billion euro, with a commitment to ensure equal access to the COVID-19 medicines, vaccines, and diagnostics. And now the EU is in the teams to strongly support COVAX as part of the accelerator to make sure that especially vaccines are distributed in an equitable way and accessible to all, particularly to the most vulnerable populations. And allow me just to highlight one point of this really excellent and important report. It says that 41% in 2018, 41% of the populations still paid out of their pockets for health services. This figure is clearly challenging us all to work on achieving UHC as defined by the Agenda 2030, aiming at quality healthcare services for all people without occurring catastrophic health expenditures. The EU remains committed to support health globally at country level and beyond COVID-19, and the challenge to sustainably address the chronic weakness of low-income countries to finance their health systems was one of the important reasons why the EU has engaged with the World Health Organization since 2011 in a joint program, the Health System Strengthening for Universal Health Coverage Partnership. Through this program, the EU supports the WHO currently in 115 countries to enforce health financing systems, among other priorities, but that is a very, very important pillar, to help them, the partner countries, to mobilize more resources domestically, and also to explore new and innovative ways to make the health systems more resilient. And in this same support, the EU is continuing to help and to fund the UHC 2030 movement and its secretariat with the intention to help strengthening the new platform which emerged from IHP Plus in order to achieve the goals Ilona has highlighted in the beginning of this session. And very shortly to conclude, yes, the EU remains committed under its new financial framework to continue its work to improve health, to continue at the global level supporting the Global Health Initiative, and also focusing more than before on country programs through the Team Europe initiative, and making sure that the COVID-19 response measures blend into the ongoing health systems and health financing strengthening efforts, and thus hopefully to achieve universal health coverage in 10 years and 20 days from today. Thank you.
Thank you, Matthias. We are now going to move to OECD, and I would like to give the floor to Mark Pearson, who is a Deputy Director for Employment, Labor and Social Affairs at OECD.
Great. Thank you very much, Claude. And of course, congratulations to the team that produced this really excellent report. It's definitely a grade A report. Well done. Of course, you get a grade F for your time management on online meetings, but that's a different matter. And we won't say anything more about that. I would say that, we love working with your team, WHO, in work on the national accounts, the system of national accounts, national health accounts. And I believe our health expenditure team has been contributing to this report, and that cooperation is fantastic. Definitely improves both our work, I think. You know, an awful lot of really important things have already been said in this session. There's no need for me to repeat them. Let me try and make just three points. The first is just for the high income countries to know that there was, of course, this spend whatever's necessary attitude to covering health expenditure at the beginning of the crisis. I think that means that what you'll expect to see is a big surge in the proportion of GDP being spent on health. Well, you probably won't. When we actually look at the data for some countries, at least, especially those with activity-based financing, we do see quite significant falls in spending at the beginning of the year. We're talking about maybe 6% falls in, for example, Belgian spending on social health insurance. It's an artifact, of course. It's just the fact that you don't have so much activity taking place in hospitals, and it probably will lead to increased spending in future years. But it will mess up how we get our 2020 data in interpreting what's going on. I think a much more important point that I want to make, though, is that although high-income countries, OECD countries, generally would say that they have universal health coverage. That doesn't mean that there aren't gaps in coverage. And I think it's been really striking that one of the consequences of the COVID crisis was how many countries did take steps to try and fill in some of those gaps. So, for example, we saw Ireland giving expanded coverage for visits to general practitioners. We had Poland expanding coverage for certain uninsured groups. Even in the United States, we did see some cost sharing being eliminated for COVID testing. And I think that shows that there is some underlying recognition, even in the policymaking community, even in those countries that have really been resistant to filling in those gaps in universal coverage, about the importance of universal coverage. And I really hope that we can use this crisis to make sure that those gaps do not reappear after the end of the crisis. I mean, there's a couple of criteria we'll have to make sure are satisfied for that to be the case. I mean, firstly, as the report makes clear, revenue diversification is very important in high-income countries as well as low-income countries. And really, I do worry about those countries with a high dependence on social contributions, about what will happen in health spending over the next few years. Much better to be relying more on general taxation. And I do also think that this expansion of coverage also requires changes in service delivery. I think we have seen, of course, big increases in telemedicine in many, many countries. That does improve access to services, at least for some groups, not for all, but for some. And so let's use it and make sure that, yes, we expand the coverage of our universal health coverage, but also that we enable the not just financial coverage, but also the access to services more generally. Last point I want to make is a more general point, which is, I think, certainly in high-income countries, we've seen a lot of stress on the importance of investment to build back better after this crisis. The focus has very much been on a green recovery, and there's nothing wrong with that. Absolutely, let's have a green recovery. I do think the need to invest in health has been a little bit lost. And instead, what we're getting is certainly a commitment to look at things like the pandemic preparedness and the amount of spending we need to cover that. And that's great, that's needed as well. But I think healthcare resilience needs more than just that. And when we've looked at the situation, I mean, I think you can make a very good case for spending, even in high income countries, about 1.5% more GDP in order to ensure that when the next pandemic comes, high income countries will be better prepared to deal with the pandemic. And there's things that we need to invest in on capital, on the data infrastructure, on workforce that we need to do. So I think this sort of report that you've done for the whole of the world, there are lessons that are in it, which certainly are not just, although that has been the focus, has been on low and middle income countries, of course, rightly so. But a lot of the general messages that you've made, I think absolutely can be lifted and applied to high income countries as well. And we look forward to working with you together to ensure that that is the case. My congratulations once again. Thank you very much.
Many thanks, Mark. I still would like to give the floor to Michael Borowitz. Michael, Chief Economist of the Global Fund, the floor is yours.
Thanks, Claude. And I just wanted to reiterate some of the comments that Mark made. I put most of my comments actually in the chat, but I just want to bring up two comments. I mean, one, just to alert everyone that the Global Fund has been one of the largest funders of national health accounts over the last decade, and particularly over the last 5 years. Both of our strategic initiatives have put in significant funding into national health accounts. And we also provide funding through our country level grants. And we do this together largely with the Gates Foundation, but we would really like to see other partners join this effort of funding global public goods or global common goods for health, including, for example, like the European Union, who doesn't necessarily fund this activity. And so it would be good to have many other partners on the table in this. And it would be good to see bilaterals and multilaterals like the EU joining this effort to fund global public goods. particularly using WHO, because I think this is one of their areas of core competency. And so I think this is a neglected area because, as Anya said, we need to figure out how to fund global public goods, and we have not figured that out at the moment. And so I think that's a critical issue. And I think the health security agenda has also raised very important issues that we need to rethink in the area of UHC, because UHC has really focused much more on expanding service coverage. And of course, we at the Global Fund are very interested in expanding service coverage for AIDS, TB, and malaria under the rubric of UHC. But we also fund a lot of population health programs. We work a lot on disease surveillance. And I think this is a critically neglected area because UHC is not just about service coverage, it's also about building essential public health functions and helping countries build that function, like the CDC function, like particularly around surveillance, around labs, and that is a very neglected issue. And this actually is important even in the context of national health accounts, because national health accounts don't necessarily cover health security. And so we really need to move forward on linking national health accounts and health security accounts in order to figure out if there's adequate funding for these core public health functions. And don't forget that the health security agenda is wider than just human health. It includes animal health. COVID is a zoonosis, and it's critically important that we think much more about how to improve the interface between animal and human health. So I would really think that we need to rethink a lot of things in relation to COVID. I mean, having worked at the OECD before, I think that that even in the area of hospitals, we need to rethink them. I was just talking to a friend of mine who works in the hospital sector in Italy and Bergamo, and having multi-profile hospitals oriented to chronic diseases, because for people with diabetes and multiple morbidities, which is the direction that we've all been moving in, doesn't really work well for a pandemic. And we should go back to look at the history of Lazaretto in Italy during actually the previous pandemic, during the plague. Because having a multi-profile hospital, you don't really want people with COVID going to a hospital with a lot of people who are immunosuppressed and sick. So I think that we really do need to do some rethinking about rebuilding the health center. And I think only focusing on PHC in this post-COVID era is not really acceptable. We need to think about hospitals. And so although the Global Fund, we're mainly interested in public health and primary healthcare, it's hard to not come out of this COVID epidemic without thinking about hospitals.
Many thanks, Michael. I think we are now through. I'm not going to speak for a long time. I just want to say that the report is out on different addresses. You can, of course, check on the P4H website, and you can also contribute with comments. The version that is up is for consultation, so all comments are welcome. And I hope that you had a good session on this Global Health Expenditure Report. I wish everybody a very good evening, night, morning still, and I hope to see you soon to collaborate on these issues. Thank you. Bye.